Hi guys, this video is about vernal keratoconjunctivitis or VKC, also known as Princatra. So, coming to the definition, it is a recurrent bilateral interstitial self-limiting allergic inflammation of the conjunctiva. So, it is an allergic inflammation of conjunctiva. Coming to the etiopathogenesis, as already mentioned, it is an allergic reaction. And here we can see type 1 hypersensitivity and type 4 hypersensitivity. Type 1 is IgE mediated, type 4 is cell mediated. Coming to the risk factors, boys are more commonly affected than girls and in the age group 40 and 20 years. It is more commonly seen in hot, dry, dusty climates. Even though it is known as Princatra, it is seen in summer climates, and it is also seen in people who have atopic history like asthma, hay fever or family history of atopy. Now coming to the pathology, the conjunctiva has hyperplasia of epithelium and adenoid layer, and in the substantia propria we can see infiltration with eosinophils since it is associated with allergic inflammation. We can also see plasma cells, mast cells and lymphocytes. Coming to the papillae, it is actually connective tissue proliferation, and there we can see vascularized papillae, and this vascularized papillae will undergo hyaline degeneration and result in hard, flat-topped appearance. So these are the hard, flat-topped papillae, which is the pathognomic feature of VKC. Now coming to the clinical features, what are the main symptoms? There can be intense, intolerable itching, which is the hallmark feature. There can also be ropey discharge, that is thick white stringy mucoid discharge. There is photophobia if there is corneal involvement, and there can also be lacrimation, heaviness of lid and burning sensation. Now coming to the signs, there are three main forms: palpebral or the tarsal forms, limbal form and mixed form. Palpebral form means they will involve the upper tarsal conjunctiva or the palpebral conjunctiva. Here we can see the hard flat top papillae, which is known as Cobblestone or Perman pattern, and these are the hard flat top papillae. And in severe condition, there can be giant papillae, that is cauliflower-like papillae present. Coming to the bulbar or the limbal form, here we can see dusky red triangular congestion in the conjunctiva. There can be gelatinous thickening around the limbus and the pathognomic feature, which are the Horner-Trantas spot. These are discrete, white, raised spots found in the limbus, and they have eosinophils and epithelial debris. Coming to the mixed form, it has the feature of both palpebral and bulbar conjunctiva, like Cobblestone papillae of palpebral conjunctiva, Trantas spot and dusky red triangular congestion, bulbar conjunctiva. Now coming to vernal keratopathy, that is the corneal involvement. Here we can see punctate epithelial keratitis, where we can see fine puncta. Then we can see shield ulcer, which are shallow transverse sterile ulcer due to the mechanical rubbing by the papillae. Then we can see vernal plaques, that is the coating of epithelial defect with fibrin and mucus. We can also see pseudogerontoxon, that is a cupid bow-shaped opacity. It resembles senile arcus. Now coming to the treatment, general measures include cold compresses, dark goggles and also relocation of the person to the cooler climate if possible. And the topical treatments include the same as that of allergic conjunctivitis, that is mast cell stabilizers like sodium chromoglycate 2%, dual action agents, that is antihistamines with mast cell stabilizers like azolastine, ketotifen, then corticosteroids, short-term control of acute exacerbation. We will give us pulse therapy. Example include fluoromethyl. So using this mild corticosteroids will decrease the steroid-induced glaucoma risk. Now we can use immunomodulators if it is steroid resistant case or shield ulcer is present. Which are the immunomodulators? Topical cyclosporin and tacrolimus. We can also use mucolytics like acetylcysteine 5%. So they will disperse the thick mucus plaques and make it thin. Now we can also do surgery if there is corneal complications present. So surgical options include supratarsal steroid injection, cryotherapy for giant papillae or surgical excision of the giant papillae with mucus grafting. So this was all about vernal keratoconjunctivitis. This is a very important exam topic. If you want a whole note, it's available in the Telegram channel. Link is given in the comment section. Thank you.